Good evening and welcome to the second day of the heart failure physicians update. I will hand over to Dr. Uday Jadhav, who is coordinating today's program. Over to Dr. Uday.
Thank you. Thank you very much, Dr. Hari Krishnan. So on behalf of the Heart Failure Association of India, the president, the prior president, and of course our mentor, Dr. Hari Krishnan, Dr. V.K. Chopra, Dr. Abram Oman, the president of the HFAI. We have for the physicians an excellent meeting today. We have with us some of the best of the faculty who can enlighten us on aspects of both imaging and clinical. We have Dr. Samir Srivastav from New Delhi, Shantanu from Nagpur, both of whom work extensively in cardiovascular imaging. And we have an excellent guest speaker with us, Dr. Gyokerelli Duki Shiara. She will speak on cardiac MRI. Dr. Venugopal will give us at the beginning a briefing of what happened in the last meeting and what are the aspects that one needs to take forward from the last meeting. At the end of everything, I'll present a short case. Thank you very much, and over to Dr. K. Venugopal.
Thank you, Uday. I think we had 2-3 talks the last meeting. One when I presented the history and physical examination aspects in heart failure, the epidemiology of heart failure, and the third talk by Professor, I've forgotten his name. Can you just ask Dr. Hari to take over for some time? I'll just join in a minute.
Hari? Vinay, can you enable me to share the screen?
Yes, you can share, sir.
Can you see my screen?
Yes.
Yes.
So I was last time I was discussing about the burden of heart failure in India. The burden of heart failure is rising in India. Even though we don't have real estimates about the prevalence and incidence of heart failure, it is likely to be in the younger population, as we have seen the data from the National Heart Failure Registry, the Kerala Registry, the ICC Registry, etc. The long-term and short-term mortality are high. 1-year mortality is 30%, 3-year mortality is 45%, and 5-year mortalities are nearly 60%. And India is considered to have the double burden of heart failure because of the rise in the prevalence of risk factors and the persistence of old age diseases. Coming to the pathophysiology of heart failure, we discussed the universal definition and classification of heart failure, where we have currently incorporated the biomarker and objective evidence of pulmonary or systemic congestion in the diagnosis of heart failure. So now onwards, we are following the universal definition of heart failure, which is proposed by the different various societies, where Heart Failure Association of India was also a part of. Now we have the different classification: less than 40 reduced ejection fraction, more than 50 preserved ejection fraction, and there is something called an improved ejection fraction when the ejection fraction previously was less than 40 and now it is more than 40. And pathophysiology, we discussed about the different aspects, the reduced ejection fraction and the preserved ejection fraction. Preserved ejection fraction, there is the relaxation of normality. But in all these, both these, there will be dysfunction of both systolic and diastolic phase of the heart failure. Then we discussed about the problems of preload, contractility, and afterload. I am not going to those details because we have discussed all those things. And finally, the myocardial injury leading on to decreased ventricular performance, cardiac output, which activates the neurohumoral system, the increased sympathetic activity, which is taken care by the beta blocker therapy subsequently. Then we have the simultaneous activation of the renin-angiotensin system and the natriuretic peptide system, which will balance and bring back the patient to the near normality, but it is a gradual downhill course in most of the patients. Ventricular remodeling we discussed, where the post-MI remodeling was the classical example, where there is an infarct zone thinning and elongation, which will lead on to the loss of the geometry of the ventricle, will lead on to ventricular dysfunction. So this was the busy slide showing the different action of different drugs, where the beta blockers were acting on the sympathetic nervous system activation, and the angiotensin receptor agonist and antagonist, and the RNA, etc., acting on the renin-angiotensin system. So basically, the pathophysiology was summarized as a reduction in cardiac output, initially compensated. The compensation was by the renin-angiotensin system and the sympathetic activation. Later, when the compensatory mechanisms fail, there's a rise in the filling pressure and lead to clinical deterioration. Therapies which will be discussed in the subsequent sessions will be pharmacological, electrical, and mechanical. Thank you. Over to Dr. Venugopal for the rest of the session.
Dr. Hari, Dr. Uday, Professor Shera wants to talk next. So I think let her have the next talk and then change over.
Okay, I think if she can go to the talk and present, Dr. Chiara can present the talk, and then we will go to the first.
Yeah, thank you. Namaste. Mera naam is Chiara hai. I learn a few words of Hindi. My husband is actually Indian, so I'm learning Hindi. I recorded my talk, so I think perhaps the IT, okay, perfect. And then I'm here for live Q&A. Thank you. Namaste. Mera naam Chiara hai. I speak only a few words of Hindi, but I'm learning. Thank you so much for the invite to be here to this important event. My name is Chiara Bucciarelli-Ducci, and I'm going to talk. I'm a cardiologist doing cardiac MRI in London, as you see from my background over here. And my talk is on cardiac MRI utility of heart failure. I'm a cardiologist and been working in this domain for almost 20 years now. So those are my disclosures. So MRI has a lot to offer, but the cardiologist has a number of imaging modalities in the armamentarium that they can choose from. And so the question is, when should MRI be used? When is SPECT or PET indicated? About cardiac CT and obviously echo. So those are all questions that are still open to some extent, but we're going to see that the ESC guidelines actually give a very clear indication when cardiac MRI is indicated in patients with heart failure. And essentially is in class 1, so it means every patient with heart failure should get an MRI at baseline. And so why? Because MRI has a lot of information to offer in the patients with heart failure. It's one technique, one machine, but there is a lot of different information can provide. For example, we can gather information about LV and RV function, acquiring cine images, very similar to echo images. But you see here how we can see the cardiac anatomy and function very, very well. And this is independent of an acoustic window. And so we acquire this image quality in pretty much every patient, except perhaps those with atrial fibrillation, in which the cine images is a little bit suboptimal. But what is most exciting about cardiac MRI is the opportunity to understand when the heart is dysfunctional, why, and deep dive in the myocardium and see if there is any fibrosis, like in this case, you see the bright area is fibrosis of the heart, or if there is inflammation of the heart, which is this bright area, different types of pictures to see different types of problems. This, to image myocardial fibrosis, we need to give a contrast agent, which will stick to the areas of the heart which are damaged. And depending how it sticks, so the pattern of contrast accumulation, it can tell us about the nature of the damage, whether it's ischemic or non-ischemic. We can also do stress imaging with adenosine or regadenosine or dipridamole, so vasodilator stress, similar to SPECT or PET. And we can look for inducible myocardial ischemia. So in the same setting, we can also rule out significant coronary artery disease. So it's a very efficient test because in one test, we get all this information and is extremely useful for the heart failure specialist to guide management of the patients. So the contrast agent is a contrast agent that sticks in the areas of damaged myocardium. Typically in the normal myocardium, the membrane is intact and you have the molecules of gadolinium sitting in the extracellular space of the heart, which typically in a normal heart, the extracellular space is actually very small. When there is a heart damage, whether it's ischemic or non-ischemic, then the contrast will accumulate. In the case of an acute infarction, for example, the membrane of the myocyte ruptures, and so the contrast can now penetrate inside and can accumulate inside and outside the myocytes. And when we take pictures, then we see the contrast accumulation. And so we see that brightness, bright is bad. When the contrast accumulates in the heart, it means there is a problem. And there is increased space for the contrast to accumulate. When the scar is chronic, the myocytes are gone, but they're replaced by collagen fibers. But the common denominator is that there is increased extracellular space. And so what happens is that we see the contrast accumulation, but the contrast accumulation looks very different depending on the different diseases. And for example, there is a pattern that is subendocardial, so partial thickness, as you see in this drawing, but here is the corresponding image, or can be transmural, so full thickness. This is the case of ischemic heart disease because the contrast accumulation follows the pathophysiology of the underlying disease. And so subendocardial transmural is the pathophysiology of ischemic heart disease with ischemic necrotic wavefront phenomenon and with damage that goes from the subendocardial to full thickness. So every time we see subendocardial transmural, we need to think about ischemic heart disease. When the fibrosis is mid-wall, so in the middle of the wall, then this is clearly not an infarct, but it's another disease process. It's more dilated cardiomyopathy. So idiopathic dilated cardiomyopathy, or could be dilated cardiomyopathy following myocarditis. In the case of hypertrophic cardiomyopathy, we can have this mid-wall fibrosis with these chunky areas of fibrosis, and this is the replacement fibrosis seen in hypertrophic cardiomyopathy. Epicardio is mainly myocarditis, which is why the pericardium is often involved in myocarditis as well. And then there is a different pattern in cardiac amyloidosis that has this zebra pattern, this typically very dark cavity, and this is typical again of cardiac amyloidosis. So what we do when we interpret the cardiac MRI, we do a pattern of recognition exercise. We look at the presence and location of this late enhancement. So let's see in the ESC guidelines the evolution on the use of CMR for clinical management. So already in 2016, ESC guidelines, CMR was recommended when echo was suboptimal for measuring ejection fraction. And you see here in class 1C. CMR with late enhancement technique, it was important for differential diagnosis of the causes of heart failure in class 2A. So there was evidence accumulating, but was not set in stones as yet. And stress imaging also had a role. This has changed massively from 2016 to the new guidelines over here in 21, in which you see that CMR is recommended for the assessment of structure and function when echo is suboptimal in class 1, and also CMR with tissue characterization for myocardial in suspected infiltrative disease, fibrous disease, inflammatory disease, non-compaction, amyloid and sarcoidosis, hemochromatosis in class 1. So it means you have to do it. And so it's very important how this indication from class 2A has become class 1 in 21. And this is a figure that shows that CMR is basically indicated to rule out all these conditions. So coronary artery disease, cardiomyopathies, pericardial diseases, infiltrative diseases, storage diseases, congenital and infected diseases. So all causes of heart failure. And so here I brought you 5 different cases of heart failure just to show you in clinical practice how we do this. And imagine those are 5 echoes, and you know the heart is dysfunctional, but you need to know why, because different etiologies carries different management. So starting with the first patient, we're going to look at the late enhancement as well, and we're going to look at the pattern, whether it's ischemic, subendocardial transmural, or non-ischemic. any other pattern that is not subendocardial transmural. So starting with the first one, we see that there is indeed late enhancement and is subendocardial in the inferior wall, lateral wall, at the apex, in the anterior wall, and again in the inferior wall. Because it's subendocardial and on certain areas, maybe at the apex transmural, then this is ischemic. And so this is an ischemic cardiomyopathy, and the patient underwent an angiogram, had 3 vessel disease. It got revascularized, and potentially you can reverse this LV dysfunction. You see there is also mitral regurgitation and left bundle branch block. The second patient is also with a dysfunctional heart. You see is more globular. There is also left bundle branch block. There is also mitral regurgitation. But when we do late enhancement, at first glance, there is no late enhancement. But if we look closely, particularly here, you see there is a mid-wall fibrosis, and this is a case of dilated cardiomyopathy. This other patient also has a dysfunctional heart. There is pericardial effusion over here. And when we do late enhancement, we see florid areas of late enhancement is here almost full thickness. Here is more in the epicardial, so in the outer layer. Here is more subendocardial. Here is mid-wall. There is also some enhancement of the right ventricle throughout. So this is a strange pattern because it seems there is some ischemic and non-ischemic patterns. But taking it together also with the pericardial effusion, and looking at other images in the mediastinum, there was lymphadenopathy, lung changes. Taking all together, this is cardiac sarcoidosis. And the fourth patient, as you can see already, there is quite a bit of trabecules and fragmentation of the papillary muscles. When we do late enhancement, there is no late enhancement. But because of the anatomy and these trabeculations, this is no compaction. And finally, the last case, there is also LV dysfunction, but is not as reduced as in the other patients. And so we see there is mid-wall late enhancement over here, basically everywhere. And the pattern here is more mid-wall, epicardial, and so this is in keeping with post-myocarditis. So with cardiac MRI, we can investigate not just the dilated hearts, but also the thick hearts. And so those are 4 thick hearts, and you see there is LVH. And if you stop here, just look at the anatomy, and which is the information that echo can provide, is not so much differential diagnosis you can make. If you do late enhancement, you recognize that the patterns are very different, and they can actually be diagnostic of different conditions. So the first patient had this strange pattern of basically late enhancement everywhere, including on the right ventricle, on the atria. There is sparing of the apex. The cavity is typically very dark. This is cardiac amyloidosis. The amyloid protein in the myocardium is really avid of contrast agent, which is why it's sucking the contrast from the cavity to the myocardium, which is why it turns out to be black. This other case is asymmetrical VH, hypertrophy, and there is replacement fibrosis. This is typical hypertrophic cardiomyopathy. This other case shows mid-wall late enhancement in the septum and in the lateral wall with a pattern that is a little peculiar, and in the context of a globular myocardium, this is in keeping with Fabry's disease. To be honest, to make a diagnosis of Fabry's nowadays, we also need another set of pictures, which is the native T1 mapping, which I'll show you in a second. And those are can be high or can be low numbers. When they're low, they indicate fat or iron. And in Fabry's disease, they will be typically low, which indicates that it's basically lipids. And this is a diagnostic of Fabry's, whereas T1 map in hypertrophic cardiomyopathy on amyloidosis will be very high, and that's how it helps making the differential diagnosis. This other pattern shows epicardial, mid-wall, subendocardial, mid-wall late enhancement, and again, this is a case of sarcoidosis, which is a big mimic of ischemic and non-ischemic cardiomyopathies, and so it can be quite a hard diagnosis to establish, in fact. So going back to the ESC guidelines in 21, I think again there is a strong recommendation that CMR imaging with T1 and T2 sequences and late enhancement are important to provide information about the structural changes, storage, infiltration, inflammation, fibrosis, and scarring. All of this. And this is important for the diagnosis, but as I'm going to show you in a second, also for the prognosis of patients. Because having a scar in the heart is bad. It's bad because it provides a substrate for arrhythmias. As you see in these papers, hazard ratio 3.4 for hospitalization and death if you have late enhancement. And this is in patients with dilated cardiomyopathy. So late enhancement, yes or no. If you have it, you see there is a downward curve. And also it can be a substrate for arrhythmia, sudden cardiac death, and VT. You see here the fibrosis mid-wall. This is a substrate for arrhythmias because there is a lot of electrical heterogeneity in this myocardium with some fibers which still normal and the scarring, and there is basically this heterogeneity, and it represents a substrate for re-entry arrhythmias. So what's interesting in the literature that it's emerging that fibrosis, it might be a more important biomarker than ejection fraction, particularly related to arrhythmias and then the implantation of ICDs in patients with dilated cardiomyopathy. In this important paper published in Circulation, it shows that patients with a dilated cardiomyopathy and EF more than 40%, which is typically a population in which you would not put an ICD in primary prevention, you see that actually when you look at the arrhythmias was very much in relation to the presence and extent of late enhancement, which is fibrosis on histology and histopathology. And so I think there is a sense in the community that there might be soon a paradigm shift from ejection fraction to fibrosis, because when the heart has a lot of fibrosis, also the ejection fraction goes down. So ejection fraction might be just basically a spectrum of what's happening in the heart. With MRI also we can image the right ventricle ejection fraction very well at the right ventricle, and therefore measure ejection fraction very well, and that's prognostically important in patients with heart failure and dilated cardiomyopathy. So you need to remember that bright is not dead. It is dead in ischemic heart disease, but bright is bad. So it shows pathology in the heart and the myocardium that should not be there. And finally, an outlook of the newer imaging techniques that are helping us to make even more precise diagnosis. We can do strain imaging, and so GLS, radio, longitudinal, and circumferential strain, similar to echo, just as a post-processing in the myocardium. And we can do this native T1 mapping, T2 mapping, and ECV. And those are native T1 mapping is a way to image also the myocardium, which is both myocytes and interstitium. T2 is for edema and inflammation, and ECV is for the extracellular volume of distribution, so to measure exclusively the interstitial space. This is expanded in various conditions in heart failure, and so we can now measure the different compartments in the myocardium to understand what's going on. And so we are at the point that MRI is becoming very close to histology, and we can image infarct fibrosis, which is this with MRI. We can image replacement fibrosis, which is what we see in the non-ischemic patterns. And we can image interstitial fibrosis, which is with ECV. So very exciting times, I think, for imaging and heart failure as well. And these mapping techniques are similar to Hounsfield units with CT. So there is a color mapping, it's number that those maps generate, and this number can be very increased, very decreased, or so-so, and that helps us understand which condition is present. As I told you earlier, Fabry's typically has native T1 mapping very, very low, and so iron deposition, cardiomyopathy, and this is to distinguish from amyloid and myocarditis, in which the T1 mapping is very much increased. So this T1 mapping becomes a key image to make the differential diagnosis. And we can distinguish different diseases, and as I said, we can study the different compartments of the heart, but this might become more complex. But just to say, that we can apply this to a number of different conditions. And this ECV, extracellular volume of distribution, there is initial information that it's associated with outcomes. So this might be a new biomarker that can help us really understanding the disease early on, and so that can help the physician, the heart failure specialist, to early detection of the disease, early start to the treatment, and possibly changing the natural history of the diseases. And so my take-home message for cardiac MRI in heart failure is the following. The CMI is indicated in the ESC guidelines in class 1, so is a baseline test that you should do pair on pair with echo and ECG, just to get a clear understanding what's going on with that patient. It can accurately measure ejection fraction for both the left and the right ventricle and volumes, and I think this is important also for device implantation, but also to follow up the patient over the period of time to see if the heart is getting better, worse, and responding to treatment. It can tissue characterize the heart very well. We can see fibrosis, edema, and scarring, and that's unique. There is no other imaging modalities that can do that. It helps in establishing the final diagnosis, but also, and importantly so, has prognostic role and can help risk stratify the patient and understanding those at risk of either hospitalization or arrhythmic events. And why? Because we can see the presence and extent of myocardial fibrosis, and this is directly correlated to these events. So I'd like to thank you very much for your attention, and I hope this talk was useful. And those are my contacts to keep in touch. Thank you.
Thank you, Professor Dr. Thank you, Professor Dr. Bucarelli. This was a fantastic talk. I think it's a huge subject. You tried to put it in a small capsule and cover. I'm sure there are many questions. Hari, shall we take all the questions at the end? You have to leave for a meeting, as I understand.
Yeah, I think we can have her questions now. And
yes, so if there are any questions, one question which came up, I'm sure you saw it on the chat box, is how safe is the contrast in terms of the EGFR? How low you can go with the LG? Is it safe? Are there any concerns about renal fibrosis?
Yes, that's an excellent question. So typically we can be concerned if the EGFR is less than 30. And so but I still proceed with contrast administration, but with caution. And I have an informed decision with the patient. It depends very much on the age of the patient, and it depends if the renal dysfunction is acute or chronic. If it's acute, I wait for the kidney to recuperate. If it's chronic and the patient is very elderly, and I think it's important we do a CMR because of the diagnostic information it can provide, we'll still proceed. I think it's important to say that the newer contrast agents are actually safe even in patients with impaired renal function. So I think we're good, and in my practice, this is not a major complication.
Yes. As you are from UK, let me ask you a little different question. When you see that patchy enhancement as we see in sarcoid, cardiac sarcoid, do you see tuberculosis as a differential diagnosis there?
That's a super question. I think sadly we don't see much of this tuberculosis, but I think I've seen actually a couple of cases. The pattern, as you say, could be similar. However, in tuberculosis we have a lot of lymphadenopathy, which also actually in sarcoidosis, but in tuberculosis a lot more in my experience. And often in tuberculosis the pericardium is also involved. So much so that I think I remember a case which was amazing. It had a patient that had an echo, and they thought he had a lymphoma of the pericardium because the pericardium was so thick, and actually the MRI revealed that it was pericarditis, constricted pericarditis because of TB. So I think with CMR we can certainly see these patients and try to make a differential diagnosis.
Can I ask one question, please?
Please go ahead.
Yeah, so a fantastic talk. Just wanted to understand, so we are getting few cases of primary atrial cardiomyopathy. How do you see MR in this subset of patients as compared to an echo? Because the LA strain has come up very strongly. So are we able to look at the left atrium by an MR in primary atrial cardiomyopathies?
Yes, so that's an excellent question, Shantanu. And so the answer is that MRI is catching up with echo, I think, for what concerns the atriopathology. So I think yes, we can, but do we do it every day? I think we don't. I think there are not so many papers there, but we can calculate the size of the atrium very well in terms of the volumetrics, for example. And we can do also atrial strain, similar to echocardiography. But I think echo is more widespread for that.
Great, thank you.
Dr. Kiara, one question from me. Two questions, actually. One is, can you identify responders and non-responders to CRT with cardiac MR? So that is ischemic cardiomyopathy with left-bundle branch block. Second is, would you elaborate on viability? Because that is what every Indian physician wants to know, because we get tons of heart failure. Majority, 60-70% are ischemic, and viability is a big question. So your comments about CRT and MR, as well as viability in with cardiac MR.
Yes, so two very important, very clinically relevant questions also. So for CRT, yes, so over here we do a CMR before CRT. I think that links to your viability question as well. If the lateral wall, which is often the one that's paced, is fully transmural, so non-viable, it's fully infarcted, basically we're trying to pace a wall that it's dead. And so I think these patients are likely going to not respond to this CRT treatment. And I think there were some papers some years ago initially suggesting this, and I think there've been more literature. So I think it's not quite indicated in every single patient in the guidelines, but I think is coming up with practice, and we certainly do that. And for viability, yeah, that's one of the most common referrals also here in the UK. I think we want to know if this myocardium is viable or not and can recuperate, whether it's hibernating. That's another scenario. It's very dysfunctional, but the scar is small, the dysfunction is quite large, and so there is a mismatch. These patients need to be revascularized, whether it's with CABG or PCI, depending on the anatomy, obviously.
Okay. Will there be any other? There is one question, I guess, that would be the final one, is the assessment of the left ventricular function in patients in pediatric cardiology. How good will be CMR in this set of patients?
Very good, and we do it all the time. I think it's actually a very important application because there is no radiation with MRI, contrary to CT, and so we can see the anatomy very well. So we do it, and in kids that cannot hold the breath, so younger than 6 years, we do under sedation, and so that's a common practice.
Thank you very much, Professor Dr. Shera. Will there be any other questions from any of our faculty?
So one in the chat regarding coronary anatomy, MRI and CT. So the short answer is no, because I think with CMR today clinically, we cannot see the plaques like endostenosis as well as CT can. What we can see, however, is the origin and the proximal course of the coronaries. So we can rule out anomalous coronary arteries. And so in the patient, for example, with syncope, or palpitations, and there is a query, you want to know whether there is myocarditis, whether there is arrhythmogenic right or left cardiomyopathy, we can actually add MRA of the coronary arteries to look at the origin and proximal course of the coronaries. And sometimes we've been seeing anomalous malignant coronaries. So that's very possible, but not for the stenosis.
Absolutely. Well said. Thank you very much. Thank you very much, Professor Dr.
Yeah,
Shera.
thank you. Thank you so much for having me at this super course.
Namaste from all of us in India. We are doing
Yes.
very well against England in the cricket, so we are very happy.
Yes,
right.
yes. Yeah.
So let's thank you very much once again.
Thank you. Thank you.
We hope to have you for a longer SCMR session. Maybe
yes,
we'll keep it
I
very
hope
exclusive
so.
because this is a capsule. I don't think that's going to fit our requirements. We
Yes.
need you for a longer time once you are not busy on all those other meetings.
Of course, and
You need
even
to
in
give us that.
person, I'm coming to India on the 23rd of November to actually get married with an Indian wedding. So I will be in Delhi for 3 weeks. So
Okay, the big fat Indian wedding. Thank you very
yeah,
much.
thank you.
very much.
Nice to see you.
Been a
Bye-bye.
pleasure. Thank you. Bye-bye.
Bye-bye.
So we move on with the second talk, and Shantanu, you are there, or Samir will go ahead first? Will Dr.
mine
Samir
is-
Srivastava?
Yeah, mine is
Shantanu, you are going ahead? Yes, go ahead, please.
Samir is
Yeah,
presenting directly.
yeah, whatever. Mine is pre-recorded.
Either which ways, it doesn't matter.
Vinay,
Hi,
can we
Dr.
play?
Uday, hi, Shantanu, hi, Hari Krishnan,
Hello.
Abraham, Engronda, hi, Chopra, sir.
Hello.
So whatever suits everybody's convenience. If you want, I can start and
Yeah, you
then.
can start
No,
sharing.
Samir, please start. Samir, please start.
Lovely.
Samir, please start.
So allow me to share my screen.
You can share.
So here I am with evaluation of heart failure in India. So first and foremost, my disclaimer, I am not a leftist, but I am a very proud left of the center. Now, there are certain problems with our country. We have very limited data. We are a different race. We developed coronary artery disease almost about a decade earlier. We have multiple blockages, diffuse disease. First MI is more fatal than the others, smaller arteries. Several differences are there. Most important is our resource crunch. If you look at the data, out-of-pocket payers still is the highest. We have very limited insurance cover for most of the population. When it comes to localization of centers, there is localization of centers of excellence, which is largely in and around the metropolis, and RHT continues to deplete lives and economy for our country, which again is a major burden for heart failure. Now, how I have designed this talk is that there are certain very blatant and dogmatic statements I'm going to make, but the way I've done it is not class 1, class 2A, class 2B, class 3, but taking the precedence from International Society of Hypertension, where there was something known as optimal and essential to be achieved. Just to set the context right, cost of treatment, if you look at in our country, we have loads of admissions. We have costs which goes into the medicines, and there are a lot of costs which goes into investigations. So we can come down, or at least have some kind of a compromise that we have somewhere that it starts suiting the pocket as well as it serves the purpose for treatment. So financial burden of heart failure in developing country, this was a cost analysis from Manipal Heart Failure Registry, which is not too long, 2021. And if you look at this, the sum and substance is that when you look at the patient's earning and caregivers' earning, which contributes to the care, it's almost about 87.4%. That is huge. So there is hardly any coverage from the government or from the insurance or from any other player other than the self-care. So where are the places where we spent lots? One is admission, where we can't do too much about it, because once there is an acute decompensated heart failure, you can't do too much about it. But what you can do is when it comes to investigations. Where is the investigative challenge is that we have resources which limit us to use just about everything all the time. That is the problem. We can't use all the investigations all the time, and we have to be prudent in what we pick and choose. These are the types of insurance, again, not going into the details of that, but like was talked last time, we have to be very careful about what we look at history and physical examination finding for heart failure and selective alternative causes. So we have to look at the patient in total with immense symptoms and signs which have to be elicited and interpreted. So this is again from diagnosis and evaluation of heart failure. Why is it important is because if you look at few things, they can really rule in heart failure or rule out heart failure, and these are not expensive stuffs. One is the Framingham criteria score, which can help us in ruling out heart failure. But besides clinical, target X-ray, because once you target X-ray, then it helps positive likelihood of a ratio more than 10, which is very, very predictive. And that helps us in targeting our cost or budgeting our cost too. This is, if you look at the ruling out of heart failure, then clinical criteria which have been drawn by Framingham is reasonable, and it establishes a negative likelihood ratio of less than 0.1, which is a fairly good way of ruling out a heart failure. So what are the Framingham criteria? These are the Framingham criteria. The major ones are acute pulmonary edema, cardiomegaly, hepatojugular reflex, neck vein distension, paroxysmal nocturnal dyspnea or orthopnea, RALS, S3, and gallop. Minor ones are ankle edema, shortness of breath on exertion, hepatomegaly, nocturnal cough, pleural effusion, and tachycardia persistent more than 120 beats per minute, even at rest. Now, if you look at it, if you have two major criteria or one major and two minor criteria, then you are almost ruling out heart failure with reasonable certainty, not with high accuracy of all the sorts, but reasonable certainty. Now, these are the overt costs which go into lab evaluation. I'm not talking about cost of training. I'm not talking about cost of infrastructure. I'm not causing. So these are the overt costs which go in evaluation of heart failure, where most of them are initial blood tests, which are electrolytes, which are BNPs, arterial blood gases, blood cultures, HIV testing, Lyme serology. These are the ones which go. These are probably not so much so needed when you're talking about community in general and not for individuals. So what is the reasonable diagnosis establishing selective things? I think this is one of the most sensible algorithms which has been given, where when you have an initial suspicion, all you have to do is go ahead, get a BNP levels done and an echocardiography. Though both of them run parallel, they are mutually exclusive. And when you talk about echocardiography, it helps us not only to find out about etiology, but most of the criteria has been set on electrocardiography, whether it is with reduced ejection fraction, with mildly reduced ejection fraction, or with preserved ejection fraction. It is basically the echocardiographic criteria which has come into existence to define all that. Not only that, diastolic versus systolic failures, you can calculate the filling pressure, not with extreme accuracy, but when you look at the mitral inflow versus the tissue inflow, E to E prime, you get a reasonably good idea about what the filling pressures of the left side are. You get very good idea about the pulmonary artery pressures. So this is one of the tests where if there is somebody who's even reasonably trained in doing echocardiography, he can help a lot. Now, these are established norms in the country, that we have a primary healthcare, we have a secondary healthcare, and we have a tertiary healthcare. I would just go by this because this is one of the most wonderful things, that in primary healthcare, we know that there is a resource crunch. And that's the reason. Just look at chest pain, dyspnea, palpitation, swelling of feet. This is enough and more to refer the person to a higher place of reference, or whether to keep the patients to themselves and evaluate. And then when it comes to clinical examination, you can go further ahead with finding out the details of the history. But it is basically in the secondary care where you can get some sensible investigations like blood investigations, X-ray chest, ECG, echo, and pharmacological therapy. However, tertiary cares, which is something like a medical college or tertiary referral centers, these are the ones where you can go ahead with evolved evaluations like CMR, you can go for SPECT, PET scan, you can go for viability studies, stress echoes, name the thing, and it should be available there. This is how it will serve the purpose in our country, because if you want to have everything everywhere, then it will be such a waste of expense and waste of efforts for a disease, which, yes, it deserves attention, but it deserves attention with a reasonable mix and match to keep the things in sanity. So these are the ones which are there. Echocardiography holds, I'm sorry, I'm an imaging person and my talk will be heavily biased in favor of echo, but this is what it does. It can show the systolic dysfunction, diastolic dysfunction, valvular heart disease, structural heart disease, and look for systemic diseases wherever you can. Then this is an algorithm which has been proposed by the American College of Cardiology. Now, if you look at it, again, the same thing is there. When it comes to soon after clinical assessment, what are the things you have to look for? You have to look for the BNPs, and you have to look for transthoracic echo, and then go further ahead to further classify it or subclassify it with ejection fraction less than 40%, 41 to 49%, more than 50%, and now the latest one is improved ejection fraction, and evaluate the precipitating factors initially. But where are we? For the Indians, we have to have mutually exclusive yet parallel two systems, natriuretic peptides and transthoracic. In case in transthoracic, you have enough and more reasons not to bother too much about natriuretic, though it has got prognostic indication value, it has got therapeutic value to see whether the therapy is working or not. Those are all things which we all understand. But in case you want to limit your costing part of it, then transthoracic echo takes the precedence, which is easily available most of the places, and people are reasonably good at managing all these things. I'm not talking too much, but these are few slides which I picked up quickly as Dr. Chiara was talking about, because if we have a mix and match of ECG and echo, then we can really come out with some sensible diagnosis. This is an ECG, low voltage ECG with a person with macroglossia, and look at what we have. We have amyloidosis on our hand, and we don't need to go further ahead, because of any other thing is going to be a waste of effort and money. This is quite classical cherry on top for amyloidosis. I'm sure Shantanu is going to talk more about it. These are more examples of infiltrative disorders like amyloid or Fabry's. Those are things which exist, and we know that in case we have to just prevent the cost factor out of it, let's keep it sensible and not push things too much, because there is no extent to which you can stop your investigations. Now, here is yet another example, non-compaction of LV. This is something which is seen more often than not these days, not because it was non-existent earlier, because the awareness was so little about it, but with echo, you can come out with very good diagnosis of non-compaction. Here is a very blatant example of a non-compacted LV, where there is a apical clot as well. And if you look at this, these are the recesses in which the blood is flowing inside. And if you have more than 3 recesses and the compacted to non-compacted ratio is more than 1:2, then you are pretty much sure that you are dealing with non-compaction. But there is a caveat to that. It should not be associated with any other structural heart disease like a valvular stenosis or a regurgitation. So these are certain things which are very dramatic here. Look at this. This is a non-compacted LV with apical thrombus. And this is example of the same going, and these are some pretty pictures. Now, not to reinvent the wheel, we already have an algorithm which has been propagated with the latest guidelines from American College and the European. Let me just take you through that what are my take for the Indian patients. So the clinical assessment, there is no doubt, there is no confusion. This is class 1, and this should be continued with the Indian patients as well. Now, this is again in patients with cardiomyopathy, a third generation family history should be taken. You have to try to find out causes. Again, same goes true for the Indian patients. When it comes to initial lab testing, now these are certain things where if you have heart failure, then lab evaluation should include complete blood count, urine analysis, electrolytes, kidney function tests, glucose, lipids, liver function tests, iron studies, thyroid stimulating hormone to optimize therapy. Again, we go by the same because there is nothing that you need to change. When it comes to biomarkers, my take on it is that it should be optional for primary care centers, essential point of care for secondary, because you have now biomarkers which can be evaluated quantitatively and qualitatively both. At secondary care point of care, you just might have only a point of care testing. But certainly, if it's for a tertiary center or a referral center, then they have to have a very elaborate, quantified kind of a biomarkers, which should be available. So this is a little bit of a difference from the American guidelines, because for primary centers, I'm not too sure whether they will be able to handle that kind of a thing. Number 2, same. If you go for the other reasons to do the biomarkers, these biomarkers again should stand classified for primary care, for secondary care, and for tertiary care. We know the limitations of biomarkers. And if these are the ones which are existing, like advancing age, anemia, renal failure, obstructive sleep apnea, severe pneumonia, embolism, pulmonary arterial hypertension, critical illness, bacterial sepsis, severe burns, these are the ones where they'll be fallaciously high. Then we have to keep factoring in all those things. When it comes to genetic testing, now this is a bone of contention for me, because it should be an optional thing for us. So where does people who need genetic testing figure in? Because you have to first classify that, does everybody need genetic evaluation? So certainly for people who have got first degree relatives and selected patients with genetic or inherited cardiomyopathies, this should be done, and counseling are recommended to detect cardiac disease and prompt consideration of treatment to decrease heart failure progression and sudden cardiac death. Now, to what extent can you pull it and you push it, and to what extent should the centers, which centers should be doing it? So my take on it is that genetic evaluation and this testing is to just keep it for research and selective heart failure referral centers, which get fed in from the tertiary care centers. And if your tertiary care centers happens to be a research or a selective heart failure referral center, then no problem, you can go ahead with that. Similarly, these are the factors implicating possible genetic cardiomyopathies. And when it comes to evaluation with any other thing except genetics, you must continue to do it at the point of care, whichever is the best available. And usually it is the tertiary care centers that they can have it. When it comes to arrhythmia monitoring, ICDs, etc., again, these can be done at very fundamental levels, because these days, wherever there is a cath lab facility, which you or I can classify it or categorize it as a tertiary care center. But if you have that kind of a facility, please go ahead and use that for treatment modalities. When it comes to cardiac imaging, again, the issue is that what all are the cardiac imaging which are available at whichever level you should optimally utilize them, rather than to push the highest end of cardiac imaging into the primary care centers, or so to say into the secondary too. This is when it comes to basic centers, you have an X-ray chest, that should be available, ECG should be available. And I would say that transthoracic echo should also become a part of very fundamental imaging, because it makes so much of a difference that a person comes with shortness of breath, and instead of treating him for tuberculosis, you find that he has got mitral stenosis. What a wonderful thing. And all you have to do is 40 seconds of imaging and you are there. So this is the kind of basic training for echocardiography which working physicians should have. And this will establish, more often than not, you'll do more service to the community rather than not doing anything. Because you, in a shortness of breath of this sort, wherever you are thinking it is a HFpEF or a HFrEF or a mitral stenosis or a mitral regurgitation, everywhere the NT-proBNP will be high. But when you want to find out really the cause and the etiological aspect of it, then echo comes in very handy. Now, this is for again, cardiac imaging. So CMR is something which should be optional for primary, optional for secondary, and optional for tertiary referral also. Most tertiary centers will have a CMR. Most tertiary centers will have an CMR, but most tertiary center will not have an individual to evaluate a CMR. That is the reason why I am insisting that CMR should be keep advanced CMR for research and selective heart failure reference center, and that is the place where they should visualize everything. So again, when it comes to PET scans, CT SPECT scan, those are the ones, again, we have to keep advanced imaging for research and selective heart failure reference centers. Invasive evaluation, we have to, again, keep it for a tertiary center or a referral center. And when it comes to exercise and functional capacity, again, this too is selectively for heart failure referral centers. There are certain clinical assessment heart failure risk scores. These scores have not been validated for South Asian population, or Asian populations, or Indian populations by and large, but they can be used very liberally, because there is, I intuitively saying, these are things which will not be too different when it comes to subjecting Indian population to that. Now, this is a landmark article which was published where they said management protocols for chronic heart failure patients. So acute heart failure is a different ball game. Chronic heart failure in India is the one where most of our own executive were there. It was authored by Sandeep Mishra, but I see Dr. V.K. Chopra's name here. Hare Krishnan is here. Hiramat is there, and last name is V.K. Bell, so I'm sure he must have also contributed some better. Now, this is a mix and match from both the worlds, and it has been very beautifully been penned down. So essential components to confirm diagnosis are clinical. You have to look at the filling pressures at rest or effort, exclusion of other diagnoses by overlapping syndromes, reduced exercise capacity, elevated NT-proBNPs. These are the ones which are essential, and this is a mix and match from both the worlds. Then it comes to what all should you look at in clinical. We have had a session already, but these are more elaborate things where you have to hunt for selective key signs like JVP, hepatojugular reflex, tachycardia, RALS, murmurs, S4, and what are the things which you have to look at in signs. You have to establish orthostatic blood pressure, look at BP lying down or upright position. There are several things, I'm sure it has been dealt in more greater details, but this is just a teaser trailer of what has been already discussed in the past. But these are the ones which are very essential. Now, when it comes to these are, again, you have to see for various signs and symptoms, duration and aggravation of symptoms. These are detailed history taking, which you can't get away with. These are the important investigations in blood work. So you have to do a complete blood work, electrolytes, renal function tests, liver function tests, blood glucose, fasting glucose, and PP glucose, HbA1c, lipid profile, thyroid, and iron studies are very important. Though probably it has not shown too much of benefit, but quality of life certainly improves when you correct the iron profile of a person, but whether it improves the survival pattern, it's very debatable. ECG in heart failure, we think that it is non-contributory, but it is probably most contributory because good about 60 to 70% of the patient, like Abraham said, would be having an underlying coronary artery disease of some sort. And this is what is important. You have to look for rhythm, you have to look for ST segment shift, you have to look at QT intervals, very important QT intervals. You have to look at the voltage criteria, because small voltage in a thin person, actually you are already very suspicious about what is happening to his heart as far as infiltrative disorders are concerned. And these are the ones which are there, and you can't get away with ECG. X-ray is probably the most inclusive thing which establishes ruling in of heart failure with a very high probability. So amongst the basic tests, so it has, if you have an enhanced cardiothoracic ratio, pulmonary venous congestion, pleural effusion, lung abnormalities, LA and pulmonary artery enlargement, curly B lines, these are the ones which you have to look for in X-ray besides whatever you find more. Shantanu is a very passionate echocardiographer, so am I, but when it comes to heart failure, these are the ones which you have to look for. And actually, these are not very difficult to be trained for people who can understand ultrasound some bit. So you have to look at ejection fraction, you have to look at diastolic dysfunction, mitral regurgitation, tricuspid regurgitation, estimation of pulmonary artery pressures, aortic stenosis, regurgitation, LA volume index, global longitudinal sprain, IVC, pericardial effusion. These are other abnormalities which you look at in form of aneurysm, scar, thrombus, etc. BNP and NT-proBNP is to rule out heart failure rather than to rule in. You have a reasonable, good idea about prognosis. You can tailor your heart failure therapy, and these are the ones which are very essential. Other diagnostic tests for heart failure like MRI, CT, single photon emission computed tomography, PET, these are the ones I will suggest to one and all that these should be kept. CMR, these are the ones to be right heart catheterization, endomyocardial biopsy. These are best kept for referral centers and tertiary centers where they have facilities of doing all these, and in case there is any researcher who's doing it. Now, these are the criteria diagnosis for HFpEF. Shantanu is, I'm sure, going to talk about it. Let me not indulge into more. And this is my almost last slide, which these are the suggested readings that just in case people want to, because it was hurried kind of a presentation, but these are the ones from where I have picked up my references from. So there is a National Heart Failure Registry, which Hari Krishnan authors. Then there are financial burdens. Then there are diagnosis and evaluation of heart failure, and heart failure epidemiology and prevention from Huffman and Dorairaj Prabhakaran. So these are the ones which I have said. And lastly, an honest confession. Largely the thoughts for Indian context and for community are there rather than for individuals. So these are for largely for community rather than individuals. That is where my take of being a leftist versus a rightist and being left of the center is concerned. All individuals have a right to choose their treatment path, but all doctors do not have that liberty. And that's the reason they must continue to have some safeguard to the interest of our colleagues in an increasingly litigious society, and heart failure being one where there is so much of unpredictability. Thank you very much for your patient listening. I'll be happy to unshare my slides and take the questions.
Thank you. Thank you, Dr. Samir, for the presentation. I think we can take the other talk also, and then at the end we can have some comments and discussion, right? That would be better.
No problem.
Shantanu, let us have your recording and then we can talk.
Yeah, sure. Hello, everyone. So today I'm going to focus on the role of echo for patients of heart failure. And this is a very important topic because apart from clinical assessment, imaging is an important entity in understanding and managing heart failure. So in 2008, in Circulation, a very important paper came. Now, this slide shows time in days, and on the y-axis is the end diastolic PA pressure. And as you can see, that if a person or if a patient is getting admitted to an ICU with heart failure related event, he or she can have hemodynamic condition earlier. So hemodynamic condition precedes clinical condition and decompensated phase by more than 2 weeks. And by imaging and by biomarkers like NT-proBNP, we can identify these patients. And if you can do it, then you can prevent their admissions in the ICU because of heart failure related. So what exactly is a heart failure? Heart failure is a pathophysiological state where the heart is unable to pump blood at a rate which is needed to metabolize tissue. And it does it by increasing its filling pressure to a higher level. So that's what is in heart failure. And there are a lot of recent changes which has come up. But the fundamental question which is needed, which is always needed to be answered in managing a patient is the ejection fraction preserved, reduced? How much is it? What is the structure of the left ventricle and now the left atrium? Is it normal or abnormal? And are there other structural abnormalities which are accounting for this clinical presentation? So associated factors. How is the creatinine? How is the hemoglobin? All those factors. So these are the three fundamental questions which every clinician to ask. And a lot of work has now come up and which has shown that ejection fraction, ventricular dimensions, both in end diastolic and end systolic volumes, the wall thickness, and the chamber geometry, all are essential in giving you information to classify and manage heart failure. So initial evaluation of heart failure by echo is mandatory to confirm this disease entity, to evaluate the severity, and to understand what exactly is the cause, the etiology of this heart failure. And heart failure by echo is divided into heart failure with preserved ejection fraction, which is when the ejection fraction is more than 50%, heart failure with reduced ejection fraction, which is also basically systolic heart failure, EF less than 40%, and you have now a new entity 5 years, 7 years back, which is heart failure with mildly reduced ejection fraction. So this is an important classification which we need to give from an echo, and also we have to provide with the hemodynamics of that person at that moment of time when the evaluation is being done by an echo. Now, the evolution of heart failure in terms of clinical stages, we are all knowing that you can have an asymptomatic LV dysfunction, you have compensated, decompensated, and refractory heart failure. But echo can now identify patients if they are picked up early in this asymptomatic LV dysfunction status, and you can prevent admission as earlier stated. So let's identify a couple of cases to understand what is the role of echo. A male patient, 40 years old, hypertensive since 4 years, smoker, non-diabetic, NYHA class 2 symptoms. Family history of hypertension, ischemic heart disease. On examination, BP of 160/100. This is the ECG, which shows some evidence of left ventricular hypertrophy. And when you start doing an echo, the information is, you can see this. This is a parasternal long axis view. And you can see the interventricular septal thickness is normally, which is 1.1 in diastole, was almost around 2. The LV mass in this male, which is around 115 and low ideally, but it was increased to 133 gram per meter square, and LV ejection fraction by biplane system is around 60%. So this was a normally functioning, normal EF patient, but has a thick heart, but the patient was NYHA class 2 symptoms, was in heart failure. You start giving more information. This is the diastolic parameters. You can get the E and A and the E by E prime. This is the tissue Doppler, and anything E by E prime of normal is less than 8, but anything more than 15 is abnormal. It indicates high filling pressure, and the LA volume index was around 38. So normal LA volume is around 34. So this patient was a hypertensive patient who has an hypertensive heart disease, had a constant LVH, a good LV function, but has almost a grade 1 diastolic dysfunction and an elevated filling pressure with an LA volume which is enlarged. So why this E by E prime is important? Because it has a prognosticate importance, showing that if a patient has an E by E prime of more than 15, they have higher events as compared to persons who have a relatively lower E by E prime. So the filling pressure assessed by E prime, which is also reflects the PCWP or the left atrial pressure, has an prognosticate importance, and we have to always get this done, and it can predict cardiac events. So the most important thing which I would like to emphasize is that we have to look at the LA volume, and it is nothing but 0.85 into area of left atrium in 4 chamber into area of left atrium in 2 chamber divided by the shorter length. And we index this to the body surface area, and the cutoff is now 34 ml per meter square. Anything more than 34 ml per meter square indicates that the LA volume is increased, and LA volume is now considered as the glycosylation hemoglobin of diastolic dysfunction. So it is all related to the LV compliance in this group of patients. And remember, one thing I would like to emphasize, that diastolic heart failure, which is now called the heart failure with preserved ejection fraction, accounts for 50 to 55% of all patients who are getting admitted with ADHF. So acute decompensated heart failure have 50% patients who are at heart failure with preserved ejection fraction. And the role of echo is mandatory in this group of patients. We went on doing the strain analysis. This is an indication of subclinical LV dysfunction, and we have done some work showing that the strains are generally abnormal or lower. Normal strain in healthy is around -19. In our subgroup of patients, it was lower down. So HFpEF is an entity and should be identified in this group of patients. And there are a lot of other things which we can look at, the vortices and everything, but I'm not going to into the detail. But heart failure is a problem, and heart failure with preserved ejection fraction should always be kept in mind in patients who are getting admitted if they have an EF which is preserved. A second case, a 55-year-old hypertensive diabetic non-smoker had an entry-wall MI, which was non-thrombolized, but now again has symptoms, NYHA class 2, maintaining blood pressure and pulse fluid okay. We again start going on the same views, and as you can see, this patient has dilated LV, both end-diastolic volume and end-systolic volumes are more, and you have evidence of severe LV systolic dysfunction, understanding that this must be a patient of heart failure with a reduced ejection fraction. The E by E prime was 10. The E prime velocities, which are normally around 8, was here as 5. So the E by E prime was anomalous. But we went on doing the strain, which is a robust marker of LV function, was almost in the range of around -8 to -9, normal being -19. So it is very important that all patients of presenting with heart failure should have their LV EF assessment. And if the LV EF is preserved, look at the diastolic dysfunction parameters, look at the filling pressure of E by E prime, look at the LA volume. But if the LV EF is reduced, that is less than 40%, you have to mention that this patient has poor LV systolic dysfunction, but also then assess the E by E prime to know the filling pressure of this pattern. Now, remember, whenever you are giving information of diastology, grading is important, because grading of diastolic dysfunction is associated with poor prognosis. Grade 3 has lower survival as compared to grade 1. If these patients don't get a guideline-directed medical management, the fourth pillar of treating heart failure. Also, it is mandatory that all patients of heart failure, whether it is HFpEF, HFrEF, or heart failure with mildly reduced ejection fraction, should have an assessment of the RV, RV size, because if the RV is enlarged, if they have RV systolic dysfunction, they do poorer as compared to a normal RV. Understanding that RV assessment is one of the key in looking at the assessment of this function. Now, I would like to emphasize and tell you something more about an important concept, which is called the strain rate imaging. And this is a very nice movie clip which shows that one muscle fiber contracts, it is going to 15% shortening, and it augments into a 60% volume reduction. That's why the EF is around 60%. And this is because of the structure of the left ventricle, because the muscle fibers has got three kinds of fibers: the longitudinal fibers, the circumferential fibers, and the radial fibers. And it is important to understand that we are now only able to assess and validate longitudinal fibers assessment by longitudinal strain, but not looking at the radial and circumferential fibers, which are also important. But you have to understand that this contraction augments into a 60% reduction. And this is nothing but a strain pathology, which is the global longitudinal strain. A negative strain indicates shortening, while a positive strain indicates thickening or stretching. And this is how the LV EF strain is assessed by the longitudinal strain, where you see all the fibers are contracting together, and they're contracting at the time of aortic valve closure. This is a peak systolic strain. Now, it is very interesting, and there's a lot of work which has come up and showed that the strains global longitudinal strains go markedly down in patients of heart failure with reduced ejection fraction, systolic heart failure, while it is more or less slightly diminished in HFpEF patients as compared to normal group. And there is a lot of interest has come up in patients who are going for cardiac oncology. That's patients who are getting cancer chemotherapeutic agents, because LV ejection fraction and subclinical LV dysfunction assessed by strain analysis is important to be assessed. So this is a patient who was on anthracycline and so a drug, and progressively the strain decreased from -22 to -16 to almost -11 over a period of time. So assessment of LV function is mandatory and it's important. So this is another patient of myocarditis, and as you can see, he had a dilated LV, poor LV function. A strain analysis was done, and you can see all the regions were contracting haywire. They are not contracting. This segment is dyskinetic, and the other segments are not contractile properly. This patient received immunoadsorption therapy, and as you can see, all the segments now started contracting on the similar side. So regional strain has not yet been validated, but the pattern of analysis gives you a pretty good information, and these are important. So the concept of cardiac performance has now evolved, and it is now robust, understanding that heart was earlier thought to be a hydraulic pump, and we used to do a Swan-Ganz catheter to understand the cardiac output and all the stroke volume and resistance. We moved on to ejection fraction and the pressure volume curves, which can be assessed by echo and LV cath. Now we are supplemented by assessment of the biomarkers, looking at the pro-BNP and the cytokines, and understanding that we have now robust in imaging markers like strain analysis, which can be done by echo and MRI to understand the contractility and the twist and untwist mechanism. So the cardiac performance is robust, assessment is robust, and we should all implement it in assessment of heart failure. Now, there has been a lot of interest also now in left atrium, and I would like to touch base that assessment of heart failure by echo doesn't end just looking at the LV.
we have to also look at the left atrium, because the left atrium is a component which gets enlarged. Just want to emphasize that assessment of left atrium, we should, if you want to look at the dimensions, please don't use M mode. Directly do a assessment by 2D margins. And the diastolic assessment incorporates, according to the guidelines, 4 figures. One is the left volume index, which the LA volume index, which I said was 34. The E by E prime, which is 14. Assessment of septal E prime velocity less than 7 or lateral less than 10, and assessment of TR velocity more than 2.8. So these 4 things are mandatory in patients who are coming with heart failure with preserved ejection fraction. But we have seen that lot of patients have a gray shade and they don't fit in all. And at that moment of time, we need something more. Understanding that the left atrium axis is different than the left ventricle, and this has to be identified for looking at the left LA focus view. And this is important to get the left atrial strain. So left atrial strain has now come up very strongly, and we have now RR gating and PP gating. RR gating is looking at the RR of the ECG, and PP is looking at the start of P to the next P. We do use RR gating much, and we get couple of changes, couple of fibers, and the first one is the reservoir phase, which is nothing but the peak atrial longitudinal strain. The second one important is the booster strain, is the PACS, and there's a conduit strain. The maximum work is now being done is on PALS, which is the reservoir strain, and the cutoff has been shown to around 38, which is positive. And there is a lot of correlation between left ventricular GLS and the left atrial strain in patients of diastolic dysfunction and HFpEF. So it is important that left atrial strain should be kept in mind, and it has been proven to be an independent predictor of all-cause mortality and cardiac hospitalization in patients of heart failure. So let me tell you that PALS work is now ongoing, and the recent suggestion which has now come up is to add the global PLS in this group of patients. And if the global PLS, which is normal than 38, if it's more than 20, you are dealing with the normal filling pressure. If it is less than 20, you're dealing with the elevated filling pressure. So incorporation of ejection fraction, structure, LA volume index, LV ejection fraction, LV strain, and LA strain, looking at the PLS, is mandatory in now a subgroup of patients. And there is some work which has come up on the role of left atrial strain with exercise. And this is our data where we showed the changes of left atrial strain in a group of patients of heart failure with exercise. And we had a prospective analysis showing that if there is a reduction in the reservoir strain, it was associated with 10 seconds reduction in exercise time. So exercise has been an important parameter to assess in all patients of heart failure, because we are still trying to understand the physiology of heart failure, the hemodynamics of heart failure, and there are a lot of work which is going on to identify and dig out many more treatment modalities. So let me conclude that ECHO is a robust tool for evaluation of heart failure, for the treatment of heart failure, and for the management of heart failure. Systolic function assessment is important because you can have ejection fraction less than 40%, more than 50%, or between 41 to 50%. You have now technological advances in ECHO to look on the function of the heart, looking at the global longitudinal strain, and now the left atrial strain, looking at the reservoir strain. And it is very important to integrate this information to come to a conclusion and for the better management of this patient. Thank you so much.
Thank you.
Yeah.
Thank you, Shantanu and
Yeah.
Dr. Samir. What we could do is now, let me present my case. It's a brief case for 10 minutes and I may have something else coming up. So once that is over, if you can just take an interaction, Abram is also there related to both your talks and I will join. So let me share the screen from my side and take my talk and then we can. Is the screen visible?
Yes, sir.
Yes.
Okay, so let me quickly go ahead and show this case. Couple of videos I could not play, but that's okay. So here is a patient who is a young boy with lupus nephritis and systemic lupus erythematosus. He came with a left-sided chest pain. He's a biopsy-proved patient. So he's a known case of SLE and he had a homogeneous ANA pattern, strongly positive on the immunofluorescence. He has a class 4 diffuse proliferative glomerulonephritis as per the renal biopsy in 2021. And he was complaining of acute chest pain, sudden in onset. It was reduced on bending forward. This is a clinical case, so I'm just presenting it like a clinical event. Blood pressure was 140/90, his pulse was 90, respiratory rate was okay, oxygen sats were okay. He had some urticarial rash on the back, some stria on the back because he was on a long-term corticosteroid therapy. He had both urticaria and stria on the back. His clinical auscultation was normal. There was no pericardial rub, no murmur. His respiratory system was okay. Liver spleens not palpable. He had some atrial ectopy with aberrant right bundle branch sort of pattern on the intraventricular conduction. His troponin I and his BNP were within normal limits. And we did an echo and the echo was okay. There was a little drop in the peripheral strain. So at this point of time, with a normal troponin and normal BNP, little reduction in strain because I immediately saw him. This was the ECG with which he came first. And these were the ectopies. So we kept him under observation. Just to see because it's a case of lupus nephritis, what's happening. And ECG settled down after a while. And this was his baseline ECG. And then there was nothing specific on the echo. All the echo images were normal. The function was normal. We did a GLS strain on him, and the GLS shows that the average strain was about minus 13.1, 13, and a little reduction of the peripheral strain. So here is a chest pain guy, young, lupus nephritis, SLE. ECG is not very specific except the ectopies, tropi negatives, BNP normal, little drop in strain. And these were his other reports. He had a little high cell count. He was on steroid long term. CRP was 0.4, C3 complement 84, high urine albumin ACR ratio, and high LDL cholesterol. Homocysteines were normal. Rheumatologist same day said, let's start with him on hydroxychloroquine. Now, after 6 hours, he got a chest pain. So this is the second episode. First episode, I was there in the hospital. After 6 hours, he had a chest pain and the ECG showed a T-wave inversion in the anterior leads. His tropi was 3.1 from 0.01, substantial increase in tropi. Now there was an apical hypokinesia and a angiogram was done because he had this chest pain and the tropi had gone. So the angiogram showed a mid to distal LAD thrombotic event. So we put him on antiplatelets, statins, metoprolol, tirofiban, and nicorandil. I'll show you the CAG report. In the CAG, in the distal segments were multiple thrombi all through the mid to the lateral part of the distal LAD, and he required. At this point of time, there was nothing else. So nothing obviously had to be done in terms of intervention. just a thrombotic disease. So we said, okay, this is SLE, very young guy, lupus nephritis, develops a thrombotic event. And this was his ECG on day 3. He has apparently evolved in his anterior leads, and he was taken for, at that point of time, his angio was done. Later, on the next day, he developed a severe chest pain. Now, he is on anticoagulants, he is on antiplatelets, and now we see a typical ST elevation in the anterior leads. He was immediately taken for a coronary angiography because the angina was extremely severe. And in the second angio, he had the entire LAD was filled up with thrombi. A thrombobuster aspiration was done, multiple runs, about 15 to 20. So good flow got re-established, and then there was nothing else being seen except a little residual LAD disease, which still showed that thrombi, right? So all that entire LAD was filled up with thrombi, aspirated, little disease at the LV apex. This is the picture of his aspiration. We are very worried because we did not know what was going on here. Here is the aspirate that came out. It looked like a tissue, in fact. So we sent it for HP saying, well, he's a young guy. We don't know what's going on around here. But then the H&E stain showed multiple fragmented tissue bits of fibrin meshwork with entrapped RBCs, neutrophils, lymphocytes. They were all interspersed, and there was no vessel tissue identified. So all this was suggestive of thrombus. A thrombuster was utilized, and this is his ECG on day 3, settled. On the day 5, he developed a shortness of breath, he developed hypotension, needed inotrope support, and IV furosemide support. So same severe pain, and this echo now showed a severe hypokinesia, and his EF, which was absolutely normal the day 1 he got admitted, now he has a low EF of 35. He developed a moderate MR. There were no vegetations, and this is his GLS now. It's dropped completely from the initial one we saw with a normal echo and drop of minus 13.6, going down to 7.6. All the segments badly diseased. A TE was done thinking whether he had a merantic endocarditis. The TE was normal. There were no vegetations on the leaflets. Other things were looked at also, apparently, LA appendage clots, because he's a lupus nephritis procoagulant phase. Nothing really turned out there. 7-day ECG, 9-day ECG slowly started settling down. He had 1 episode of syncope while getting out of the washroom. He was monitored for 48 hours, did not show any significant ectopy. This is day 11. Slowly settled down. And a MR was done, and it was planned and done. And you can see the anterolateral and the inferolateral segment showing a transmural MI. And these are the MR pictures. Now, if you look at the right lower part, he also had linear thrombi. You can see that linear thrombi here, where you see the lucent sort of shadows. So this was a microvascular obstruction and a thrombi on the LG. Very nice pictures, right? And this is where he has ended up with a 35% EF, and this was his MR reports, the detailed report of his MR. So a hypokinesia or akinesia of the LV segment, except the basal septum, a part of inferoseptal and mid-inferolateral, everything else got involved. EF on MR was 30. He was discharged with statin, and you may want to take this discussion upon colchicine, on dapagliflozin, on nebivolol, on torsemide spironolactone, on ramipril, trimetazidine, and then his ECG later were okay. He was evaluated for vasculitis, APLA, Cianca, all workups were negative. He continued to remain at LVF of 35. He developed a thrombus, small thrombus at the apex, and finally, this was the strain which I did on his follow-up examinations, the anticoagulant dose was optimized. Normal coronaries, no thrombus. Here is the cardiac CT coronary angiography because he refused for a further angiogram. So we had to do CT, but the CT was good, clean. You can see the LAD absolutely clean. I did not see anything in the distal vessel. The opacification was excellent. Nothing to tell me that the LAD distal also had anything. So all his coronaries were okay. Why have I presented this case? That young guy with a ACS with cardiac failure develops a HFrEF. How strain imaging helped in these patients, how CMR helped us understand what's going around. This patient, we have started colchicine by the recent data, but also because of the anti-inflammatory properties that are expected. And the question is, how do you treat this sort of heart failure? Because truly speaking, it's probably not related to plaques and atherosclerotic plaques or ischemia. This is a procoagulant phase which has caused this. EF has dropped. With sacubitril valsartan, should we go by the same pillars of heart failure treatment? We have done that, except that instead of sacubitril valsartan, we have given him an ACE inhibitor. So ACE inhibitor, dapagliflozin, beta blocker, small dose of torsemide with spironolactone, aspirin, no ticagrelor, and low dose rivaroxaban, hydroxychloroquine, and corticosteroids. This is the therapy. So this becomes a heart failure patient now to be continued to looking at the LG. Thank you. I may have a parallel meeting where I have some 10 minutes comment, but please, if Dr. Abraham, Samir, and I'm listening to you, but please take this discussion forward, including the two prior talks by Samir and Dr. Shantanu. Thanks.
So, one question on your presentation. I'm still very confused that why did he have syncope? He has all the reasons to be having syncope. But if you see the ECG, which that rheumatologist had asked, there is a short PR interval just in case.
There is the first one has a short PR interval.
Correct. So he has a variable kind of a PR interval. Most of the ECGs don't show PR interval variation except one or two, which are very short. So I think it was basically some kind of a AV nodal conduction. He must be having some kind of a fast pathway there as well. It seems like this. Rest, if I were to do an angiogram, I would have probably shot his renal arteries also.
You would have done what?
I haven't shot renal arteries also because they lupus people are very prone to develop prothrombotic lesions in
the renal vessels too. Yes. Yeah. Point well taken. Yes. Yes. Any other comment on? Can we take the discussion of the two talks also, because we haven't really all the three talks, in fact, looking at CMR.
There was one question which was put in the chat, sir, that how important is use of ECG when doing echo, as most echo doers don't do it. This, I think, was Rahul Arora who had posted this. So I'm sure everybody be agreeing with me. There is no ECG which can be done without an ECG. You have to have an echo and ECG simultaneously. You just cannot have echo without ECG. You have to do it. Except that when you are doing a per operative transesophageal echo in the operation theater, or if you are in a dire emergency where you just want to see for pericardial effusion and dampener. Otherwise, because otherwise you can't get any of the parameters which you are looking at. You won't be able to getting for strain. You won't be. There is no question. ECG has to be there with that.
Okay, can I get the comments from all of you about two very basic things? First question is, who should be doing echo in India? Should physicians they should learn echo and be part of, because they have the clinical background they know. So in the opinion of the panel, should physicians learn at least the basics of echo, especially in the context of heart failure and valvular disease, the basics. Second comment is about the remote sensing kind of thing is that you transmit through Bluetooth to a center. So some kind of, even the non-medical people just putting the probe on the chest. So the comments about both from each of you. Dr. Samir, you can start.
So, Abraham, I will go a step forward. It should be done by even MBBS people. And not only that, they should be doing something known as POCUS, point of care ultrasound. So that if they don't find anything wrong with the heart, at least they can put in a probe and look at the gallbladder too. Because those are the things which are very useful in evaluation. And not only that, if you want to have a substitute for BNPs, people should be learning how to do lung ultrasound. They can really see it well. The shadows of B lines are so dramatic that nobody can miss it, and it's not difficult. Abraham, my biggest frustration is that why should not anybody be doing echoes? If you can pick up a mitral stenosis and stop the patient from taking nebulization and steroids, what a wonderful thing you have done.
Yeah,
Or vice versa. Or vice versa.
Yeah, I absolutely agree with the Samir. I think it should be done by anybody. If technicians can do that, definitely, because many of the places technicians do their course. I think it should be done by physicians, and because they know the anatomy, physiology background, and the clinical background of the patient also he knows. So he will be the better person to image and find out whether something is wrong with simple measurements. No, LV function, the valve anatomy, very simple measurements. Everybody can learn so easily. Put some color and see whether it's a gross abnormality, subtle abnormalities, diastolic dysfunction. You need not learn, but the basic abnormalities they can detect, and that will change the management of heart failure by missing cases or getting into unnecessary investigations and management, especially the lung ultrasound, where I think most of the casualties will have these machines in the major hospitals. So I think it should be done by physicians, and as Samir suggested, even by the general practitioners also, if they have a machine and they are in the casualties.
You know, the biggest problem, sir, the biggest problem is this very draconian law called PNDT. Fortunately for you, you people don't face it so badly in South India because it doesn't exist so strongly there. But in North India, you know, the machine has to be certified, the man has to be certified, the place has to be certified. And then it's difficult to get licensing from the PNDT actually. That's the problem. Otherwise, it should be done. Handheld devices are being marketed and they are being propagated all over the world, except in our country. They are a substitute for stethoscopes, sir.
Yeah, but the social issues we have to sort out by educating people and all, but that is always there. So.
Okay, now there's a question on pediatric echo, LV dysfunction due to congenital heart disease. Chandanu is there, or Samir can take that question. What about pediatric population?
Sorry, I missed on that. What is the question, sir?
The pediatric population, heart failure in pediatric population, as well as congenital heart disease.
So actually, one of the best modalities to look at things is ECG, echo, and X-rays for pediatric population, and then take it forwards, because most of the times you'll not have an idiopathic kind of a cardiomyopathy there. Most of the times you'll have some structural heart disease, except that I remember the paper by Dr. Savitri Srivastava, where she found that in children, one of the very common causes for cardiomyopathy is hypocalcemia. And then that became a norm to do calcium evaluation along with thyroids and KFTs and everything. We still continue to do that, but I'm not too sure for the adult population. But certainly, echoes in children is the one which captures the diagnosis best. Any more questions, sir?
Yeah, some more questions were there. Chat box. Very important cardiomyopathy. He may reverse is normal prediction. So regarding peripartum cardiomyopathy, they have asked a question. So majority of the people will recover, but the problem is that it can recur in the subsequent pregnancies. And the question is, when do you stop the drugs? So that is a very difficult question. It is recommended because the third edge of study has shown that when you stop the drugs, 40% of the patients had recurrence of heart failure, even if the ejection fractions are normal. So it is advised to continue the disease-modifying agents, not the diuretics, but the disease-modifying agents indefinitely. That is a recommendation. But in peripartum cardiomyopathy, there are studies which have shown that patients who are fully recovered without any evidence of LV dysfunction in the form of normal strain imaging and all, probably they probably if they are willing to accept the risk, they can undergo the second pregnancy also. That is what. So comments from Samir.
So if there were a few big no-nos for subsequent pregnancies, whether it is primary pulmonary artery hypertension, aortic dissections, Marfan syndromes with dilated aorta, peripartum cardiomyopathy, these are the few big no's for subsequent pregnancy. And my recommendations always is that if you want to have second baby, you might as well have an adopted kid rather than risk your wife to it. These are the things. But the problem is that if you lost that child, because the maternal desire becomes so strong that some women would want to take that risk. So I completely agree with you. But the biggest problem is that in a peripartum cardiomyopathy, if they have recovered, then what should you do for subsequent therapy? Because this is different from heart failure with improved ejection fraction. This is a separate subset at all.
Yeah.
Where there is a where we know that probably it is the antigen antibody reaction of the fetus to the mother, which is not getting exposed now. So I'm not too sure whether we should continue indefinitely on disease modifying agent.
So another question on sacubitril, is it indicated in peripartum cardiomyopathy? Abraham.
As of now, pregnancy, it's contraindicated. After pregnancy, the patient is not breastfeeding has to be stopped in peripartum cardiomyopathy. So if the breastfeeding is stopped, then after that, the LV dysfunction is poor, maybe for at least the LV recovers, it can be tried.
Yeah, I think the guideline directed management is same as any LV dysfunction. If the patient, the only thing is it will be secreted in the breast milk and the baby takes it. That is a risk. But otherwise, the treatment is same as that of any ventricular dysfunction. So,
the data may be lacking, but intuitively it makes sense to continue with the same GDMD.
Yeah.
Because data even is lacking for cancer cardiomyopathies, where there is some data for beta blockers, there is some data for enalapril, but ARNI, very, very limited data. Now it is emerging. But
in pregnancy, all the RAS blockers are contraindicated. So
during pregnancy, certainly you can't do it.
Yeah. Another question is, what is the role of colchicine in the management of this lupus patient with HFrOS? Because I missed that session. I had some other assignment. So can one of you answer that?
Yeah, this is treated as a, that's a little difficult question to answer because all the studies with colchicine in acute as well as chronic situations were on atherosclerotic cardiovascular disease. This particular thing seems to be a prothrombotic. But another way of looking at it is it's a highly inflammatory state. So anti-inflammatory medication may do some benefit. So theoretically, there's some theory behind it. Guidelines wise, I would say there is no guideline on non-atherosclerotic cardiovascular disease MI as of now. So will I give it? I will individualize. It's a difficult call.
But if there is a markers of inflammation are elevated because 70% of the heart failure is due to ischemic heart disease, atherosclerosis. So in case if it is a proven ischemic cardiomyopathy and there is a residual risk in the form of inflammation by elevated inflammatory markers, I think it is indicated. So it can be.
But this boy was already on steroids. If there is some,
I don't know. I didn't know the background. So
that's what he said, that it was he was on steroids for a long time, and that's his blood pressure was 140/90 or thereabout. No, these are things I wish science knew more, because if that was the logic, then even statins should have been working, because more than the hypolipidemic agent, they have an anti-inflammatory action, and so should colchicine work. But over and above, when a person is getting already steroids, which are the most potent anti-inflammatory drugs known to mankind, I'm not too sure whether it would have been helpful for this kid. Like Abraham said, no, we'll have to individualize, and like the way you said, I think it is individual approach.
There is one question about LV function assessment after CRTD by MRI. I generally do not do it. There are MRI compatible CRT devices are there, but the pictures are very beautiful because the synchronous contraction can be seen, but as a general rule, I don't do it. But before CRTD, sometimes I do cardiac MR, especially if it's a lateral MR and the lateral wall is absolutely scarred, as the guest speaker said, then the benefit may be very less. So that's how I look at the CRTD and cardiac MR.
Post CRTD, like regardless of how safe they are MRI compatible, you have to reprogram them prior and then subsequently. Once you are reprogramming them prior, then the purpose is lost, because then the effect of CRTD is lost. I think the best way to assess LV functions and dyssynchrony post CRTD is again echo. When it comes to scarring, like Abraham said, it is very important that these days, if you are having a scar of that sort where you know that, or if you're not getting that very toddled LV apex on echo or MRI, then it is better to do a bundle branch pacing rather than going for CRTD. But again, the limitation is very few people do it, and even you have to be trained for it. But that is one option in cases of a scarred lateral wall. What do you say, sir?
Yeah, I agree. Hari?
Yeah, same. I fully agree with that. I fully agree. So I think echo is the one which is available now. MRI has its own limitations, the cost. I think MRI.
And why should you do it? What additional information will you get?
Yeah,
you want to see an LV function.
Yeah, I think you can do it more serially. You can see the serial changes. That and all echo, the same modality must be used for serial monitoring. So echo is the best.
Easier.
And it is available. So every time the same physician can do it and see the response. I think.
So my leftist intuitiveness comes again. If you have to, we do about 150 echoes a day. If you want to do the same quantum of MRIs, you need 15 machines.
The problem with the MRI is that the interpreter, those who are interpreting should be having adequate expertise.
Right.
That is the problem. I think in India, if you take the number of people who can adequately evaluate a cardiac MR are very limited. So that is also that part also we have to consider. So, and all the MRI machines are not having cardiac coils also. So that also is a limitation. So that also we have to consider.
Today you can find it because you're at 8:57.
Yeah.
So thank you. Let me express my thanks firstly to all the physicians and clinicians who have joined us today for this meeting. It has been a wonderful meeting. I thought there was a lot of learning from the three talks we had. Designed on echocardiography, Dr. Samir Srivastav's talk, Dr. Shantanu's talk, and Professor Shiari's talk. There were excellent comments from both Abraham Uman, who is our president for HFAI, and Dr. S. Hari Krishnan, who has been a mentor with V.K. Chopra for the HFAI. We look forward to such meetings. I think we continue to have these clinical interactions. And please do join us. We'll keep you informed. Thank you, the Hallmark team, Vinay, who has helped us in organizing everything. Thank you once again.
We
all
have
of you.
one minute left, and there is some question in the chat box which I see. Present status of newer molecules like vericiguat or
Omecamtiv and
omecamtiv.
Yeah. So, Abram, why don't you comment on it?
Vericiguat is still after the standard 4 or the big 4. But advantage of vericiguat is it's indicated up to GFR of 15. So where I position is worsening heart failure in spite of GDMT, or some of the GDMT cannot be tolerated due to some reason, and the renal failure per se. So the Victor trial reports are not yet out. So Victoria was one drug, but I would give the 4 ARNI, SGLT2 beta blockers and MRA. I will try my level best to get them on board, then consider vericiguat, especially in worsening heart failure.
When the patient is getting recurrent admissions with heart failure, even on all 4 drugs, then I think we can add, because that is the one which is available. We can add.
So that's the label use. That's the label use. So
And
thank you very much.
Omecamtiv, the myosin stimulator is not yet available in India. Probably
Not FDA approved, I think.
it is just come.
It's come? Okay.
Oh, okay. I didn't know that. It's available now.
No, it's not available. I don't think it's FDA
Not
approved.
as yet. Not as
Not
yet.
as yet.
Yeah.
Thank
I
you
think
very
the other questions can be answered in the next session on 16th November on Thursday. I think Dr. Chandana Sengupta will be presenting the recap of the session, and then we will have the other sessions which follow. Will include acute decompensated heart failure case, how to stabilize it, and then the initiation of the guideline-directed therapy by Dr. Giuseppe Rossano, with the president of the Heart Failure Association of the ESC, and planning discharge, the points to ponder by Dr. Abraham Umman, and finally how Dr. Ajay Bagal will discuss how the case was managed. I think it is a very important session. I think I invite everyone to join that session, which will be very, very important. So
Thank you.
that is on 16th November, Thursday.
Yeah.
From 7 to 9 p.m. in the same platform. Please do join. So thank you, everyone. Good night.
Good night, sir. Wonderful. Had a wonderful learning and teaching. Thank you.